Hello, guys. So I'll be talking about pancreatitis. And the first topic to start off with pancreatitis is acute pancreatitis. So here I'll be covering the etiologies, the treatment, diagnosis, and the complications associated with acute pancreatitis. So the materials that I have used here is, the commonly used material, so step 3 EU world, and also med bullets. So you get some free material out there. And also, if you want to subscribe to their peak material, is also awesome. So let's begin with pancreatitis. So here we go. So acute pancreatitis, patients present with sudden onset of epigastric pain that radiates to the back, which is associated with nausea and vomiting and fever chills, right? So sometimes, not always, patients get this flank ecchymosis called Gray-Turner sign and periumbilical ecchymosis called colon sign. Now, these represent hemorrhagic pancreatitis. So not always patients with pancreatitis presents with such signs. Um, so these signs can be seen in acute pancreatitis, hemorrhagic pancreatitis, or hemorrhage, which could be, any abdominal hemorrhage. On palpation, there will be epigastric tenderness. Now, what is the pathophysiology of pancreatitis? It's an inflammation caused by the leakage of pancreatic enzymes. These pancreatic enzymes cause autodigestion of the surrounding tissue that results in pancreatitis. Okay, so moving on to the studies. So you suspect a patient with pancreatitis. So what are you going to do? Well, not always you do these studies, but abdominal radiograph is not indicated in patients with pancreatitis. Anyway, it shows a sentinel loop. All right, so what is a sentinel loop? As isolated and dilated loop of bowel seen in inflammatory conditions. Um, of this, the most important one is an abdominal ultrasound. Okay, so you do an abdominal ultrasound to assess for gallstones. All right, so the ultrasound may show you an enlarged pancreas, abscess, or gallstones. Next up is a CT scan of the abdomen and pelvis with contrast. Now, again, you don't need to do a CT scan always in suspected patients with pancreatitis. The only three indications of a CT scan in patients with pancreatitis is when the diagnosis is uncertain, or if there is failure to improve clinically, and lastly, if there is a presence of Gray-Turner or colon sign, as this may indicate hemorrhagic pancreatitis. Okay, next up is a CT guided fine needle aspiration. So the indications for that would be an infected necrosis or for gram stain and culture to guide antibiotic selection. Next is the lab studies, which includes amylase, lipase, and calcium. So of amylase and lipase, lipase is the most sensitive for pancreatitis, which will be elevated, and calcium will be low because of saponification. Now, the diagnostic criteria of acute pancreatitis is there are two of three of the following, which is acute onset epigastric pain, the classic pain associated with pancreatitis, epigastric pain radiating to the back, along with a high serum amylase or lipase level that has to be thrice the upper limit of normal. Very important. Now, if you do not have these two criteria, and if your diagnosis is under question, then the third criteria or requirement would be imaging studies, such as a CT scan. Okay, so if you have at least two of three, then your diagnosis for pancreatitis is made. Okay, so one of the differential, now keep this in mind, that a peptic ulcer disease certainly, looks a lot like pancreatitis because it also has epigastric pain. But when you do the pancreatic enzymes, that's not elevated in case of peptic ulcer disease. Okay, now what would be the management approach? Now, you've got to remove all the offending agents when possible. Treatment will be guided by etiology of the pancreatitis. And we're going to talk in detail about the causes of pancreatitis. So the first line treatment for pancreatitis is supportive. You want to put the patient on NPO, okay? We want to put the pancreas at rest, all right? And then start off with fluid resuscitation, all right? Pain management is very important, and electrolyte repletion. Now, a very important point is that you don't want to put the patient NPO for more than 24 hours. It's important to start off oral or tube feeding as soon as possible as the patient tolerates. Okay. Next up is IV antibiotics. Now, IV antibiotics, I'm not a good fan of antibiotics in acute pancreatitis. Studies have shown that adding antibiotics doesn't help unless there is a clear indication for it. Okay? And then other treatments include ERCP and surgical debridement. ERCP is indicated if you suspect a gallstone pancreatitis. Okay? And then surgical debridement is indicated if there is a necrotizing pancreatitis. All right? Now, then the complications. Complications may be a pseudocyst, fistula, abscess, hemorrhagic pancreatitis, pleural effusions, often on the left side, chronic pancreatitis, and DIC. Or, it's not included here, ARDS is also a known complication of acute pancreatitis. Now, this is actually a very brief about acute pancreatitis. Now, let's go in depth. Here we go with with the URL material. So here is acute pancreatitis, the etiologies, right? The etiologies, okay, so what's mnemonic? The commonly used mnemonic is I get smashed, right? For pancreatitis. So I here stands for idiopathic, gallstones, ethanol, trauma, steroids, mumps or malignancies, autoimmune disorders, scorpion stings, hypercalcemia or hypertriglyceridemia, ERCP, and drugs. Now, what kind of drugs? Now, again, there's another mnemonic here for drugs. A son's lad felt I met Sam Carve, all right? So here are the drug lists, which is A here stands for acetaminophen, sulfonylurea, opiates, and NSAIDs. Lamivudine, didanosine for lad. Felt these drugs are thiazide diuretics, losartan, enalapril, and furosemide, the diuretics. IMET here stands for isoniazid, metronidazole, tetracycline, trimethoprim sulfamethoxazole. Then SAM stands for steroids, azathioprine, and mercaptopurine. And lastly, CARB here is carbamazepine and valproic acid. Of these, the very important ones are carbamazepine and valproic acid, the anti-epileptic drugs associated with pancreatitis. So these drugs, what they do is that they are either they cause hypersensitivity reaction. They may be associated with ischemia due to hypovolemia that goes more with the diuretics, or increased viscosity of the pancreatic enzyme. So all these results in pancreatitis. Okay, so these are drugs that causes pancreatitis. So the clinical presentation, as we said, is acute pain radiating to the back, epigastric pain. Severe patients may present with hypoxemia and also hypotension and tachycardia. So, as I said, the required diagnosis criteria would be a characteristic pain, amylase lipase thrice the normal limit, and MH consistent with pancreatitis. Then the treatment. Treatment, as we said earlier, volume resuscitation and pain control, oral or tube feeding within 24 hours as tolerated. Okay? And for gallstone pancreatitis, you want to do an ERCP if you suspect a common bile duct stone. Okay? A cholecystectomy to prevent further recurrence. That's again a very important point. Hypertriglyceridemia pancreatitis, you treat with apheresis or intravenous insulin, and fibrate to prevent recurrence. Okay? So, in addition to a CT scan, CT scan actually has a very low sensitivity in the first 72 hours of presentation. And so you don't usually do a CT scan in the beginning, okay, if you have a high suspicion for pancreatitis, okay? So this is all the about acute pancreatitis. Now, we said that the drugs, yeah, the drugs are associated with pancreatitis are these. A son's lad felt I met Sam's curve, right? Now, drug-induced pancreatitis is not very common. It's about approximately 1% of cases of pancreatitis. And therefore, if you suspect pancreatitis, don't forget to dig into the medication's history of the patient. Okay? So, although the rate of DIP for any specific medication is low, certain medications are more strongly associated with the disease. Okay? So, it's very important to dig into the history of the drugs of the patients. Okay? Now we have spoken about the causes, the diagnosis, the treatment. Moving on to what would be the best next step, right? So you suspect a patient with pancreatitis. What would you do next? All right. So this question basically gives you a patient with a high lipase, okay, which is 3 times the normal upper limit. Then the abdominal ultrasound was done, which shows a normal gallbladder. Okay, now the patient is started on IV fluids, antiemetic, and pain control medications. What would be the next step? Certainly, you'll do a lipid panel because you want to know the etiology. So always dig into the etiology. Okay, so once the diagnosis of acute pancreatitis is made, the etiology must be determined. And in case of lipid panel, why do we do it? Because we said hypertriglyceridemia is associated with pancreatitis, and any level more than 1000 mg per dl is consistent with hypertriglyceride-induced pancreatitis. So, what determines the severity of pancreatitis? Okay, so this is another important and very commonly asked high-yield questions in the exam and also in what rounds. So you have a patient with pancreatitis, and how do you predict the severity of the patient, right? So that's a question, or in other words, I would say what would be the prognosis of the patient, right? There are a number of criteria. One of them is Ranson's criteria. There is Apache score, which are kind of outdated because they're very cumbersome to use. Easier ones now are the SIR score and the BISAP score, Atlanta scores. These are very commonly used, easy to use scores. Okay, to remind you, the Ranson's criteria. The Ranson's criteria is applied on admission and during the first 48 hours of admission. So on admission, as you remember, if you remember the mnemonic, it's GA law. So G here stands for glucose more than 200, age more than 55, GA, and law. L here stands for LDH more than 350, and AST more than 250, and the W stands for white blood cells more than 16,000. So that's on admission. Now during the first 48 hours, it is the mnemonic is Kevin Hub. Kevin C stands for calcium less than 8. Hubs here is hematocrit drop more than 10%. Okay, PO2 is less than 60. B is base deficit more than 4. And S here, BUN more than 5. And S is fluid sequestration more than 6 liters. I don't recommend knowing the Ranson's criteria anymore because it's cumbersome to use and not commonly used now. So it is better, the only important point you want to remember for the exam is that the most sensitive of Ranson's criteria is white blood cell. Okay, so that's about Ranson's criteria. Now, I said that Ranson's is now outdated. Apache is quite cumbersome. What do you do next? So you depend on the SIRS criteria. Now, SIRS here is basically the systemic inflammatory response syndrome, right? So if you have any of the more than or equal to of the following, then you classify, you stand for SIRS. Okay, so an easy mnemonic for SIRS is with heart. Okay, with W here stands for white blood cells more than 1200 or less than 4000. Okay, and HEA of heart stands for heart rate more than 90 beats per minute. Rate is respiratory rate, more than 20 per minute. And the T here stands for temperature more than 38 degrees or less than 36 degrees. If you have any of the two, then SIRS criteria is met. Okay. Now, having said that, if the patient has SIRS, then you calculate the BISAP score. The BISAP score here stands for BUN, for B. I here stands for impaired mental status. S is SIRS. This is why you want to know the SIRS, okay, of the patient. Then A here stands for age, and P here stands for pleural effusion. And remember that pleural effusion mostly on the left side, as we said earlier, right? Pleural effusions often on the left side. Great. So that is BISAP score. Now, BISAP score, 0.2 points, lower mortality, 3 to 4 points, higher mortality. Okay, so this is very common and easy to use score compared to Apache score or the Ranson's criteria. Next up is the Atlanta score. Atlanta score, the main 2 points regarding the Atlanta criteria is organ failure and local complications. So organ failure may be failure of 3 main organs: the heart, the kidney, or the lungs, or could be any other. And local complications associated with the pancreas, peripancreatic fluid collection, pseudocyst, necrotic collection, or pleural effusion. Okay, so these are local complications. So Atlanta criteria states mild, moderate to severe. Mild is no organ failure with no local complications. No organ failure, no local complications. Moderate is transient organ failure, transient meaning less than 48 hours, with or without local complications. Severe is persistent organ failure more than 48 hours. So this is how Atlanta criteria is classified into mild, moderate, and severe. This is for very severe pancreatitis. Okay, so this was all about the pancreatitis. Oh, 1 minute. I forgot to mention the most important criteria, like the Ranson's criteria, SIRS, BISAP scores. These are used commonly. But what actually is very important to evaluate on admission is hematocrit and also the BUN levels. A hematocrit more than 44 and a BUN more than or equal to 20 mg per dl on the date of admission is very important, because these represents or reflects greater hemoconcentration from third space loss. Okay, and 24 to 48 hours after admission, CRP is very indicative and correlates with the severity of the pancreatitis. Any level of more than 150 of CRP is very sensitive. Okay, so that's the prognosis. Then we will talk about the the hypertriglyceridemia induced acute pancreatitis. So hypertriglyceride, like we said, high triglycerides can cause acute pancreatitis. Okay, the risk factors is genetic predisposition due to family dyslipidemia or poorly controlled diabetes. So for the clinical features of triglyceride-induced acute pancreatitis is you have to have those 2 of 3 criteria of acute pancreatitis. And a very important point is triglyceride more than 1,000. A 300 level of triglyceride doesn't make the diagnosis for hypertriglyceride-induced acute pancreatitis, okay? With or without eruptive xanthomas, all right? Now, how do you manage the patients? Definitely, for acute, you want to manage the acute pancreatitis initially, how we said. Then you want to know the etiology, right? You do the labs, and boom, you find out high lipids, high triglyceride. Okay. Now, What do you do then? You want to know the severity of the disease. This is why you calculate the Atlanta, right? Is the patient in a mild condition? Is a patient or does the patient have a moderate or severe condition? Now, if the patient has a moderate to severe condition, like fever, tachycardia, leukocytosis, lactic acidosis, or hypocalcemia, you want to do apheresis. Okay, apheresis is basically removing all the triglyceride from the blood, plasma, just like plasmapheresis, right? And then basically remove the triglycerides from the blood. And but definitely you don't do that in the beginning. You initially start off with the insulin therapy, okay, if not severe or if apheresis is unavailable. And lastly, you want to prevent that to occur again. So you start the patient on fibrates to prevent the recurrence. So how does insulin help clear that triglycerides in the blood? Going back to first aid, the microbiology, we just want to focus on this part here. Here is the bloodstream, right? Okay, and these are the tissues, the adipocytes. Now you have the triglycerides circulating in the blood, okay? And you have the lipoprotein lipase enzyme here, okay, which facilitates the triglycerides to move into the adipocytes, okay? So what insulin does is that it activates more lipoprotein lipase and allows more triglyceride from the circulation to move into the adipocytes or the other tissues, okay? So this is how insulin helps in clearing the triglycerides in the circulation into the tissues, okay? And that's what we want. So insulin can be used to treat hypertriglyceride acute pancreatitis by activating lipoprotein lipase and increasing the movement of triglyceride out of the plasma into the tissues, all right, and prevent further damage, okay? In addition to starting on fibrates to prevent recurrence, you also want to advise the patient to increase exercise, a low-fat diet, and alcohol abstinence, all right? So this was about high triglyceride. Next up, as we said, what's a very common cause of pancreatitis is gallstone pancreatitis. So if you suspect gallstone pancreatitis in a patient, it's just a very common cause, and you want to do an ultrasound anyway for any patient with pancreatitis. So let's say you found out a gallstone, all right? So what do you do then? So this is exactly what the question states. So lipase here is high, okay? And you do an ultrasound, you see multiple gallstones, all right? And but no abnormalities are seen in the common bile duct. Okay, your TAG levels are normal. What do you do then? Okay, so you would do a cholecystectomy during this hospital admission, or you would do a cholecystectomy in 6 to 8 weeks. Okay, now these two are the very commonly answered questions. Now, this patient, remember that this patient is, this looks like a mild disease. Okay, it's not a severe disease. So in case of any mild disease, you want to do a cholecystectomy during this hospital admission itself, okay? Cholecystectomy in 6 to 8 weeks is recommended for severe pancreatitis, okay? You want to resolve the infection, the inflammation of the pancreas, and then do a cholecystectomy in 6 to 8 weeks, okay? So let's dig in. So cholelithiasis with elevation of alkaline phosphatase, gallstone pancreatitis is the most likely diagnosis. Okay, how do you describe a mild disease? It's characterized by lack of both organ failure and local or systemic complications. Should undergo a cholecystectomy within 7 days. And this is what exactly is the Atlanta score. So there is no organ failure and no local complication. It's a mild pancreatitis. So when you have that, you send the patient for cholecystectomy within 7 days. Okay? Then a delayed cholecystectomy should be considered in patients with severe gallstone pancreatitis, which is characterized by persistent failure of one or more organ system. All right, like I was said, going back to this picture, Atlanta, severe persistent organ failure, more than 48 hours. or with or without local complications. In that condition, you will delay cholecystectomy to about 6 to 8 weeks. Okay? Now, what else? Now, you have diagnosed gallstone pancreatitis and you want to do a cholecystectomy within 7 days of admission. But remember that in addition to the gallbladder, cholecystectomy is basically just cutting off this area, just removing this gallbladder. But how about the biliary system? You want to assess the biliary system again. So if the patient is low-risk patient, during cholecystectomy, you may do intraoperative cholangiogram and assess the biliary tract. Okay, and if there is any stones or any blockage, you may remove it along with the gallbladder. Okay, but at the same time, if the patient has persistent biliary obstruction, okay, patient presents to you with persistent biliary obstruction, the elevated alkaline phosphatase, and hyperbilirubinemia. Basically, what you want to do is, prior to cholecystectomy, you want to do an ERCP. Okay, so ERCP can be obtained prior to cholecystectomy in patients with with evidence of persistent biliary obstruction. Okay, so for persistent biliary obstruction before cholecystectomy, do an ERCP. Okay, great. So that was about gallstone pancreatitis. Next up is the complications associated with pancreatitis. Now we said earlier, let's go back to the summary, said these are the complications: pancreatic pseudocyst, fistula formation, abscess, hemorrhagic pancreatitis, pleural effusions, chronic pancreatitis, ARDS, DIC. So what does this say? Let's go and read. Okay, so this patient has, he was diagnosed with acute pancreatitis. Okay, now day 8 of hospitalization, this patient complains of persistent unchanged abdominal pain. In addition to that, there is fever, hypertension, tachycardia, the laboratory analysis reveals leukocytosis. This is basically saying that there is some infection process going on, right? And you suspect infection around the pancreas because the patient has pain in the same region. Okay, so in that condition, what are you going to do? You do a CT scan of the abdomen with contrast. Okay, boom, let's go back to the summary. What does the summary say? Here it says, what are the indications for a CT scan? Okay, and diagnosis is uncertain. Okay, I did not have elevated enzymes, but I have a pain. Yes, then I think I should do a CT scan. Yeah, now there is failure to improve clinically. This patient of mine, on a day 8 of hospitalization, still there is pain with infection. So failure to improve clinically is another indication for a CT scan of abdomen with contrast. Okay, so here you go. The question is answered. So CT scan of the abdomen with contrast. Okay, so this patient has leukocytosis, hypotension, abdominal pain. So she should be evaluated for infected pancreatic necrosis. This is one of the complications. In addition to that, this is an indication to start off with antibiotics. Okay, so you will definitely do an abdominal CT scan with intravenous contrast. In addition, you'll start with intravenous antibiotics such as meropenem or fluoroquinolone with metronidazole. Debridement of the necrotic material is also considered. All right, next up is so another complications of pancreatitis is inflammatory fluid collection. Okay, now inflammatory fluid collection, now this can be is basically classified as early, less than or equal to 4 weeks, or late, more than 4 weeks. So if you have a fluid collection or patient presenting to you with a fluid collection within less than or equal to 4 weeks, these lesions are usually vol-less. Okay, so these can be pancreatic pseudo pancreatic peripancreatic fluid collection, and acute necrotic collection. These are wall-less. Okay, these are early presentation. Late presentation, more than 4 weeks, these are well-defined, walled-off necrosis. These can be a pseudocyst, okay, or necrotic changes. So in this, these inflammatory fluid collections are very dangerous, okay. These fluids can cause abdominal pain, obstruction, or fistulization. Fistulization into adjacent organs. It can be blood vessels as well. So these blood vessels can be eroded and form pseudoaneurysms. All right, it can result in GI hemorrhage. So it is important to clear off these inflammatory fluid collections. And in addition, these can be super infected. Okay, so these are the complications of acute pancreatitis. So this is all about acute pancreatitis, the etiologies, to the complications. This has covered all the questions from the U world. And next will be sessions on chronic pancreatitis. Thank you.